now move to our second controversy that will be presented by Dr. Katie Ruddy from Mayo and Dr. Mamounas from Orlando Health Cancer Institute. So Dr. Ruddy is going to start. She's a professor of oncology at Mayo in Rochester. She co-leads Mayo's Symptom Control and Survivorship Cross-Disciplinary Disease Group, is vice chair of the Multinational Association of Supportive Care in Cancer, member of the NCCN, and co-chair of the Symptom Intervention Committee for the Alliance Cooperative Group. She's an active breast medical oncologist with a focus on patient-reported outcomes as well as prediction and prevention of toxicity. Dr. Mamounas is medical director of the Comprehensive Breast Program at Orlando Health, professor of surgery at the University of Central Florida, and clinical professor of clinical sciences at Florida State University College of Medicine. He's chair of the NRG Oncology Breast Committee. He's trained in both surgery and epidemiology, and his focus is on multidisciplinary care of early disease. Dr. Ruddy.
Dr. Mamounas and I would like to thank the organizers for inviting us to speak about duration of endocrine therapy. These are our disclosures. We're going to start with a case presentation. I'll provide some summaries of the data we have on extended aromatase inhibitor and tamoxifen use, and then Dr. Mamounas will speak about the potential use of CTS5, CTCs, and commercially available genomic classifiers to inform these decisions. Our case today is a 60-year-old postmenopausal woman who was diagnosed at age 55 with a 2.5 centimeter grade 2 ER/PR positive and HER2 negative grade 2 invasive ductal carcinoma. She had 2 lymph nodes containing macrometastases and an Oncotype DX score of 16. She had breast-conserving therapy, including radiation and 5 years of letrozole, and received 6 doses of zoledronic acid, and yet a recent DEXA reveals osteoporosis with a T-score of negative 2.6. She's tolerating letrozole relatively well with some arthralgias and vaginal dryness, but a good functional status. So our question is, will she benefit from extended endocrine therapy? And if so, for how long, with what drug? Should we use CTS5 as a tool to estimate risk of recurrence in this setting? And do genomic test results inform our decisions? It was 17 years ago that MA17 was published, revealing that patients who were treated with approximately 5 years of adjuvant tamoxifen and then randomized to letrozole versus placebo did experience an improvement in breast cancer-free interval with the use of letrozole. And in fact, in those with lymph node positive disease, we saw an improvement in overall survival. Of course, this came with increased side effects of hot flashes, arthralgias, myalgias, and alopecia in those who received letrozole. With the release of the MA17 data, NSABP B33 was unblinded early, and thus a similar patient population who had been randomized to exemestane versus placebo had actually interestingly similar findings despite crossover of many patients from placebo to exemestane. We did see an improvement in breast cancer-free interval in the exemestane-assigned patients with more grade 3 toxicity in that arm as well. The primary endpoint of disease-free survival was not statistically significantly different between the arms in this study, but in patients with node-positive disease, we did see improvement in disease-free survival. NSABP B42 is probably the most relevant for the case we're discussing today, because in this study, all enrollees had received at least some aromatase inhibitor as part of their initial 5 years of adjuvant endocrine therapy. And here the randomization was to an additional 5 years of letrozole or placebo. Disease-free survival and overall survival were not different between the groups at 7 years, but breast cancer-free interval was improved in the letrozole recipients. And here you do see that there was a reduction in distant recurrence in those who received letrozole, and that really was only evident in the latter part of follow-up after the 5 years of treatment. Interestingly, symptoms and osteoporotic fractures were similar between the groups in this study. Other pivotal trials to mention, the SALSA study, which suggested that 2 years of additional endocrine therapy with aromatase inhibitor, here it was anastrozole, was comparable to 5 years in terms of disease recurrence and death outcomes, but there were more fractures in patients who received 5 years rather than 2 years of additional aromatase inhibitor in the SALSA trial. In MA17R, most patients were about 10 years after their initial diagnosis at the time of enrollment, and because most had received 5 years of tamoxifen and then 5 years of letrozole, and then were randomized to letrozole versus placebo for an additional 5 years. And here, again, letrozole was seen to improve breast cancer-free interval. Tamoxifen is also a reasonable option for many patients in the second 5 years of adjuvant endocrine therapy. In the ATLAS trial, we saw improvements in breast cancer recurrence rates and breast cancer mortality with 10 versus 5 years of tamoxifen. Now, that came at the cost of increased pulmonary emboli risk and increased endometrial cancers in those who received longer duration tamoxifen. We saw similar results from ATOM, and this is particularly important for premenopausal survivors. I would note that there's still a very important unanswered question with regard to whether or not ovarian function suppression should be used in the second 5 years of adjuvant endocrine therapy for premenopausal survivors, and I hope we have trials to guide us in this in the future. I think at this point, many of us do consider ovarian function suppression for those at highest risk who remain premenopausal. So coming back to our case, will this postmenopausal survivor with T2N1 disease benefit from extended endocrine therapy? If so, for how long? I would say yes, she probably will. I would offer 2 to 5 years, and I would generally prefer an aromatase inhibitor to minimize risk of clot and endometrial cancer. I do believe she needs to be concurrently treated for her osteoporosis. With that, I will turn things over to my co-presenter.
Thank you, Katie. And so as Katie already discussed with you, there is benefit from extended adjuvant endocrine therapy, but at best that benefit is modest, particularly for patients who receive a prior AI therapy and continue with aromatase inhibitors. So the question, of course, is how can we optimize selection of candidates for adjuvant endocrine therapy? And we have some tools to do that. First of all, we have tools that refine the risk of late recurrence after 5 years of endocrine therapy. We're going to talk about clinical pathologic algorithms, mostly CTS5. We do have now circulating tumor cells and perhaps even circulating DNA that helps us potentially define risk of recurrence. And of course, genomic classifiers that predict risk for early recurrence have also shown to predict risk of late recurrence, and some of which also may predict benefit from extended endocrine therapy. So CTS5, or Clinical Treatment Score post 5 years, is a tool to predict late distant recurrence after 5 years, essentially to predict risk of recurrence between years 5 and years 10, using clinical pathologic factors such as the age of the patient, the number of positive nodes, tumor size in millimeters, and important to remember that when you use it online, and grade of the patient. This was developed by Ms. Dowsett and was developed in the patients from the ATTACK trial and eventually validated in the Big 198 trial. And you see here the algorithm that includes the clinical pathologic factors with coefficients. You see here the validation in Big 198. The solid lines is the ATTACK trial findings, and in the dashed lines, the Big 198 findings. And again, this is very easy to assess online. You can go and see the calculator online if you put CTS5 calculator. You can put your patient characteristics, but again, emphasize to you that this is in millimeters. So if you put 2.5 centimeters won't work. So make sure you put actually millimeters. And I did that actually for the patient that we have here in front of us today, grade 2, age 60, and 2 positive nodes. And the 5 to 10 year risk ends up being 15.2%. We'll discuss the accuracy of this a little bit in a minute. In more recent data sets, the CTS5 was actually evaluated in the TEAM and IDEAL trials for prediction of risk of distant recurrence and benefit from extended endocrine therapy. And both in these trials, in a large cohort of patients, almost 6,000 patients from TEAM and 1,500, almost 1,600 patients from IDEAL trial, the CTS5 was significantly prognostic in terms of low, intermediate, or high CTS5 score. And you can see the numbers. However, actually what was evident as well was that the CTS5, when the high clinical score is obtained, it overestimated the risk of distant recurrence in the TEAM trial, and actually both intermediate risk and high risk overestimated the risk of distant recurrence in the IDEAL trial. It's possible because the ATTACK and Big 198 were trials that were conducted a little bit earlier than the TEAM and IDEAL trials, that the risk of recurrence has actually have come down a bit. But nevertheless, you have to remember that, for example, for the patient in front of us, the risk may be a little bit less than the CTS5 tells us for high clinical risk. Now, in the IDEAL trial, CTS5 was also evaluated for prediction of extended endocrine therapy benefit, and it did not predict benefit from extended endocrine therapy, meaning that the benefit was irrespective of a CTS5 clinical score category. Another approach would be to look at circulating tumor cells, and Josh Sparano published this now about 4 years ago, looking at the effect of CTCs on prognosis for patients from a large ECOG study, 5103, that evaluated adjuvant chemotherapy with or without bevacizumab. They obtained CTCs 5 years after diagnosis, and this was associated with late recurrence in ER-positive, HER2-negative breast cancer, as we see here from the curves between CTC negative and CTC positives, where in the univariate analysis, there was about a 10-fold increase in risk of recurrence if you were CTC positive than CTC negative. So about 5.1% of the patients had CTC positive assay. 6.5% of the patients had clinical recurrence, and in the multivariate analysis, actually positive CTCs gave a 13.1-fold higher risk of recurrence. About a third of the patients with recurrence had a positive CTC assay at a median of 2.8 years before clinical recurrence. So as you will see from the next study I will present to you about ctDNA, CTCs tend to then tell us that the recurrence is imminent within a year or two after positivity of CTCs, and that may not be as useful of a tool unless we can demonstrate that we can actually alter the natural history by changing the treatment at the time of CTC or ctDNA evaluation. So recent data from Dana-Farber looked at ctDNA for prediction of distant recurrence in a prospective trial of 103 patients with high risk stage 2, stage 3 hormone receptor positive breast cancer, diagnosed over 5 years. And they did whole exome sequencing of the primary tumor to detect minimal residual disease. They then evaluated it at consent, and then 6 to 12 months, every 6 to 12 months. 83% of the patients had successful WES, and with median follow-up of 10.4 years from diagnosis and 2 years from the first sample, they had 10% of the patients that had positive MRD, and then 6 patients, 7.2%, developed distant recurrence, all of whom had MRD positive median ctDNA lead time of 12.4 months. So very short lead time, and eventually distant recurrence occurred. There was a patient with a local recurrence that essentially the MRD was negative, but how this patient potentially did not develop distant recurrence after that. So you see, of course, the big difference in the curves, but again, the critical question here is, can we alter the natural history when the CTCs become positive? In other words, either put the patients back on endocrine therapy or change the therapy at that time. And the answer to that is still not here. In terms of gene expression profiles, we can tell pretty much that pretty much all the commercially available assays that predict risk of early recurrence also predict risk for late recurrence, as it was shown here with EndoPredict, the breast cancer index, the PAM50-ROR, and the 21G recurrence score in patients with high ESR1 levels. However, we have data pretty much mostly from one assay, and as you will see now, even from a second assay, whether any of these genomic classifiers predicts benefit from extended endocrine therapy. And a component of BCI, the so-called H/I ratio, which is a homeobox B13 interleukin 17B receptor ratio, has been found to be predictive of endocrine therapy benefit with extended endocrine therapy. First, in the MA17, as we see here, there was a significant interaction, and the absolute risk for patients with high H over I was 16.5%, statistically different for the patients that received letrozole versus placebo. In the low H over I, there was no significant benefit. So this was a first demonstration, and then in the Transatom trial, 5 versus 10 years of tamoxifen, it was shown that again, BCI H over I high results in significant benefit from extended tamoxifen, but BCI H over I low does not, with a hazard ratio here of 0.35 for a BCI H over I high and 1.07 for BCI H over I low, and you see the absolute benefit of 10.2 versus almost minus 0.2 in that trial. So a confirmation of these findings from the MA17. And then more recently in the IDEAL trial that took patients with 5 years of endocrine therapy with tamoxifen AI or the sequence and randomized them to 2.5 to 5 years of letrozole. The same findings with H over I high, having significant benefit from extended letrozole, 5 years versus 2.5, and no difference with H over I low. And the majority of these patients have received an AI in the first 5 years. So 3 studies that actually were concordant in terms of the findings. We did evaluate BCI H over I in the NSABP B42 and reported that at the ASCO meeting in 2021. In our trial, the primary endpoint was relapse-free interval. We did not see any interaction between BCI H over I high versus BCI H over I low, with a hazard ratio here 0.83 for the high, 0.69 for the low. But because, as Katie showed you earlier, the benefit in distal recurrence in B42 occurred after 5 years, we did a conditional analysis where we conditioned for the first benefit in the first 4 years and the benefit from year 4 to year 10 in a more updated analysis of our data. And in that analysis, we see that there was a significant benefit from BCI H over I high, but not BCI H over I low after year 4. No benefit, significant benefit was seen in the first 4 years for either of the groups. But again, the interaction was not statistically significant. Most of this benefit was actually realized in patients with no positive disease, where they benefited after 4 years if they were H over I high, but not if they were H over I low. No negative patients did not seem to benefit in any of the categories, but again, the interaction was not statistically significant. In B42, we also evaluated MammaPrint as a predictor of distant recurrence, and here the endpoint was distant recurrence as opposed to RFI, and we can see that patients with MammaPrint low score had a significant benefit with hazard ratio 0.43, but not patients with MammaPrint high with hazard ratio 0.65 and not significant difference, although the interaction here was not statistically significant as well. But for the secondary endpoints here of disease-free survival and breast cancer-free interval, there was statistically significant interaction showing benefit in MammaPrint low patients, but not in MammaPrint high patients, and you see the hazard ratios here. Again, so indicating that there is an effect with MammaPrint in these patients. I also urge you to see the presentation by Laura Van Veer looking at the effect of MammaPrint in the IDEAL trial on Friday in this meeting. Within the MammaPrint low categories, we separate patients MammaPrint ultra low versus MammaPrint low but ultra low, and it appears that most of the benefit from extended endocrine therapy occurs in patients with low but not ultra low, although again the number of patients with MammaPrint ultra low is pretty low and the power to detect differences is limited. Now, to finish, what do the guidelines tell us? Well, the guidelines, the ASCO guidelines say that we don't need to use any of these assays to determine risk of late recurrence for patients that are N0 or NED after 5 years. But for patients N0 or N1 with 1 to 3 positive nodes, then we can use breast cancer index for extended endocrine therapy. And of course, for more positive nodes, we don't have to. And we can also use CTS5 to determine risk of recurrence in postmenopausal patients after 5 years of endocrine therapy. And essentially, the NCCN guidelines tells us the same thing, that BCIH over I high versus low can help us identify patients that benefit or don't benefit from extended endocrine therapy. So how might biomarkers help us? Of course, this is a patient that probably would need extended endocrine therapy, but if the patient had significant side effects and wanted to avoid it, a BCIH over I may help us if it's low, not to give the patient extended endocrine therapy, or at least limit it to maybe 2 to 3 years after the first 5 years. Thank you very much for your attention.
Thank you so much, Dr. Mamounas and Dr. Reddy. Okay, show of hands. Who uses either a genomic or a circulating biomarker test to help decide whether to use extended adjuvant endocrine therapy? Yes. No. Okay. A little work to do, Dr. Mamounas.